My name is Mateus. I'm a professor of economics here at Lancaster University, and I'm sharing this seminar and this presentation with Rebecca Fish, that was the researcher, the qualitative researcher in this project. Before I start my presentation, this project has suffered several delays and then the knock-on effects from COVID. So we have been struggling a bit with doing this with the initial time frame that we were given, and I would like to thank also Claire Ashmore for the support she has been giving us throughout the last couple of years that this project is ongoing. It's very much appreciated, everything that you've been doing us to keep us going and helping us to finish this as we intended to. So this, let me see if I can, yeah, so this is the project team. I know that David is also attending this seminar. It was myself, Mark Limer, that is my colleague here at the Division of Health Research, Dr. Ewan Lawson, that is based at Lancaster Medical School and is a clinician. And we also had Dr. Anna Maiden, that is a public health Blackpool Council, was at the time, she's not anymore, public health consultant at Blackpool Council. And then we had Rebecca and David. Rebecca was focused on the qualitative research, and David was looking into the quantitative analysis that is, it's not yet finished, so we are still working on that. So you might get a second webinar on the quantitative results next year, maybe, who knows, hopefully. So what was known about the topic, that there was limited evidence on Buvidal use in community settings, but it may be of benefit for those who find it difficult to attend for daily supervised medication. The aims of our study were to add to the body of existing evidence on this medication, and also to contribute to help policymakers on a wider use of Buvidal across the country. So this was proposed as a mixed method study with qualitative interviews, and we were interviewing service users, staff, and the key stakeholders, and also a quantitative analysis of a Delphi database with the information on people receiving Buvidal. That is the part of the analysis that is still ongoing. There had been issued, NICE had issued some guidance in 2019, and it said that this treatment, so Buvidal, could be an option for when there was a risk of storing medicines at home, people with difficulties getting to the supervised medication, and people in custodial settings due to supervision challenges. But there is a big but with the Buvidal treatment. It's the cost. So it was up to 10 times more the usual opioid replacement therapies like methadone. So what was the evidence at the time? So and this was based on 4 existing studies. Participants perceived benefits as increased convenience to travel and work. There was reduced stigmatization, and there was no need for daily medication doses. So all these things were seen as a major plus from the participant side. There were mixed experiences with the ability for the buprenorphine to hold participants throughout dosing interval. There was also evidence regarding reduced contact and disconnection from healthcare services as they were reported, and this was an issue for some participants. Some participants also reported clarity of mind was not a barrier to retention in treatment, and retention rate is higher than the median 6 months retention for either methadone or other buprenorphine. There had been a peer-led evaluation in Wales in 2021, and that was based in 94 patients, and 75% of those patients were male, and they had reported that they had been able to rebuild their lives, getting jobs, reconnecting with family members, and called the medication a game changer, life change, and even a miracle. It was also reported by these patients that they had felt reductions in cravings, lower levels of anxiety, reductions in offending, and also abstinence from illicit opioids. The negatives reported by those who had left the program is that they felt unprepared, that there was not enough support, not enough information, overwhelming emotions. They couldn't manage the side effects that they were feeling, and finding new ways of living was difficult. So the recommendations from this peer-led evaluation in Wales were face-to-face consultation, signposting to information about early experiences of using Buvidal, morning appointments, and discussing with peers, wraparound support, including activities and peer support. So this is a summary of what was known regarding the effects of Buvidal on participants. So I'm now passing to Rebecca. Rebecca, you need to unmute yourself.
You're on mute.
I'm just trying to move the slide on. Can you? Oh, okay. Hang on. I can't move. Okay. Okay. So this is why the study is important, really. The massive increasing deaths related to drug poisoning in England and Wales. In 2023, it was the highest number since records began. And the sort of demographic where the highest deaths are found is consistently is it Generation X, 40 to 49 years now, and opiates really feed into these drug-related deaths. So in sort of half of these drug-related deaths, and those are the ones where we definitely know that it's recorded on the death certificate, so involve opiates. And basically Blackpool local authority is consistently has the highest age standardized mortality rate for these deaths. When you look at the listing on the ONS, it's always the top for probably a couple of decades, I would say. So that's why we were looking at this opioid replacement therapy, opioid agonist therapy, Buvidal. So Buvidal is the trade name. It's an injection that people get either weekly or monthly. Usually people start having it weekly and then move to monthly. And it replaces methadone, which is the sort of traditional opioid replacement therapy. But when you have methadone, you have to go to the chemist each day and have and take it supervised. The other option is buprenorphine in wafer form, which you can take under your tongue, so you can maybe have more control over when you take it, because you're allowed to keep it yourself at home. But there are various issues with this as well. So it's kind of hailed as this new treatment because it's an injection and then you can go away and get on with your day or your month or whatever. So I guess this is why it was sort of piloted or trialed first of all in Blackpool, because of this massive drug-related harm. So there you go, that's Blackpool. It looks really shiny and nice, but it's not really shiny and nice throughout. So you can see here, compared to the northwest and this sort of average for the rest of England, Blackpool is way up there. There's quite a lot of drug-related harm in the northeast, but Blackpool is a massive outlier in the northwest. Okay, so in terms of what I did, I took on the qualitative part of this study. So it was quite difficult to recruit. It was difficult to recruit people who had desisted or exited Buvidal therapy and people who didn't want to go take Buvidal, just because you know, obviously they're not going to be in the same contact with the service. So we were in a community service. In the end, 13 service users I interviewed, 6 staff. So those were like nursing staff, practitioners, so the people who give the injections, and 4 stakeholders. So those were public health workers. And the interviews lasted between 25 and 75 minutes. And most of them were in online, but I did 4 face-to-face with service users at the service. There was a semi-structured format, and service users only received £15 voucher for their time. So I asked people about their experiences and perspectives, and the interview schedule was designed with input from people with lived experience right from the start. I wanted to get a sort of rounded view about Buvidal, so looking at it from different perspectives. There's a lot of evidence, as we've seen before, from service users, including a peer-led evaluation, but bringing in the perspectives of the prescribing staff and the practitioners and the public health workers gave this study a real sort of rounded view, looking at the different perspectives, so how people saw things differently, and the different kind of struggles in terms of commissioning, as well as individual struggles, and also the lack of information because it's such a new treatment. So the reason why I do qualitative research is because I like to see the sort of nuances. I like people to be able to tell me what's important to them about the subject, rather than me going in with my own agenda, which is generally what happens with surveys. So, finding a deeper sort of understanding about experiences, and looking at, the different perspectives, so where people are coming from and how that might differ in terms of their plans for the future or their notions about and experiences. So I always think it's quite interesting to look at those to see what surprises you, really. So for the rest of the presentation, I'm gonna just give an overview of the themes that came out. There were loads. I'll just give a quick summary of the themes that came out, and then read out a couple of interesting quotes about each theme. Okay, so in terms of like the positive aspects, people were, the people that I talked to, in particular the service users, were really, really pleased with this treatment. People were describing it as a game changer, a silver bullet, something that just one woman said it brings the sunshine back to her, it's brought the sunshine back to her life. So really quite gushing responses, and that's why often it's important to get different perspectives, because you need more more nuanced views to give a proper evaluation, I think. So people were saying that it was really helpful for their lifestyle. So people were getting jobs, they were able to get jobs and travel, go on holiday, look after their children and things. They were reconnecting with their family, because I guess people who have used drugs in the past can often experience family breakdown and relationship breakdowns. People felt more resilience to take on adversity, so they felt like people said things like to me like, I feel more confident to, apply for jobs or to do this without feeling like I need to go back on the drugs type thing. And then people were comparing them with other sort of replacement therapies. So they felt that compared to methadone, they felt more alive. People felt more clarity of mind. They felt not addicted. There was no rattle. People felt that they were avoiding having to go to the pharmacy, which was real positive for them, because obviously at the pharmacy, you know, there's predatory people outside wanting to get you back on the drugs, and also you know, your name's called out and people are watching you while you take the methadone. So it's not a nice experience. And just this idea that there was no craving. So quite a few people said it felt like they'd never even taken drugs. You know, they were clean. And in terms of staff and stakeholders, they were happy that this treatment allowed more choice of what they could offer people. And they felt that it might bring people to engage with the service who might not have done normally because they had this offer, and that it might, you know, meet a previously unmet need, in that case of bringing, you know, hard to reach or whatever the term is these days, people, and ultimately by doing these, it would reduce health inequalities. So a couple of quotes. This is a man service user. Buvidal, in my opinion, if you can get it to the right people, it's a game changer, because I was the worst of the worst, I'll be honest. And you see, it made me want to become a better person, control my temper, think how I treat people now, you know. It's a game changer. And this is another man. At the moment, I've got a lot of problems at home. My mum's on her way out, like, you know what I mean. But I know for a fact if I weren't on this Buvidal, I'd be taking heroin and crack cocaine. So just this idea of resilience and, you know, gaining relationships back, which will have knock-on effects with self-esteem and everything else. So in terms of comparisons, I'd been on methadone for years. You feel sluggish on methadone, and this gives me energy, and that's quite an achievement. That's a woman service user. With methadone, I knew by 9 o'clock in the morning I had to go and get it because I was feeling unwell. This, you're more awake, aware of your feelings, you're not getting sedated anymore. And that was, you know, a double-edged knife, really, because when your feelings are coming back, your emotions are coming back, that's not always great. It's a lot to deal with. And this leads me into challenges. So people were talking about availability. So some people had been put on Buvidal in prison, and when they moved to different areas, this wasn't available. So people were concerned about that. There were a few mentions of side effects. So at first, people were experiencing strange digestive issues, a dip in mental health, which was more likely to be the men at first, and a dip in their sex drive and issues with sleep. And these were all experienced at first, but these kind of wore off. But the thing that was enduring were lumps in the skin. So a lot of people who have taken drugs in the past are quite slight. And the fact that it's prolonged release means it kind of stays in the skin for a little while and leaves lumps that are quite sore. So there was an issue with that. Emotional challenges. So when clarity of mind comes back, people remember things, and they, you know, we're all trauma informed these days, so we understand that these sort of feelings of guilt and issues from the past can flood back. So that was quite a big challenge for some people. Taking away choice. So as I said, you know, with the buprenorphine wafers, people felt more in control, sometimes saying that, you know, if they started to feel strange, they could just take a wafer and they were more in charge. Whereas going for a month without an injection was a little bit of a worry. And housing and health services. So when you're taking Buvidal, you're still taking a substance. So some housing services will only accept people who are abstinent. And health services weren't often aware of the Buvidal treatment and what they could offer in terms of pain relief and even what this was all about. So some people were finding that a challenge. Some people started taking different drugs, alcohol, crack, cannabis, just because I guess they're embroiled in that kind of lifestyle. They're used to self-medicating at first, but the people that I talked to, this generally wore off particularly due to this clarity of mind that they started to enjoy. In terms of staff and stakeholders challenges, they were worried about the cost and the availability. They were worried about the extra staffing needed for the wraparound services and the sort of administration rather than it being at the chemist. They were concerned about the infrastructure going forward that's going to be needed, and they were worried about lack of engagement on behalf of service users who might just come in for their injection and then go away for the month, and they're not seeing practitioners each day or each week, and might not have that structure to their day. So some quotes. At first, it was hard getting to grips with those emotions coming back, and guilt, that was a big one. It was okay once I got to grips with them again. That's a map. This is a nurse. Quite a few people have mentioned to me when they started it, they really struggled to sleep. Some people I don't think are ready for it because they do work out pretty quick that the opiate receptors are blocked. And once they realize it does, their choice is taken away. So I think some of them like to keep that choice. That's what I was talking about before in terms of a woman I spoke to who felt like the monthly injection wasn't going to keep her from rattling, and she had a really full-time job and caring responsibility. So she was worried that she would prefer to have the choice of being able to take the wafers when she needed them. In terms of supports, right, so all of these benefits that I've talked about are in the context of a massive sort of wraparound support system that was offered at Blackpool in the community service. So there was a special, lived experience department, and there was lots of activities offered and psychological support, and key workers who experienced themselves in addiction, what it's like to be in that situation, which was really important for people's recovery. They mentioned, and some people mentioned the reasons for not using them. They've done them all before, and they wanted the Buvidal so that they could move on and get a job and not have to engage with services as much, which was fine, right? But most of the people really found this wraparound support to be key. And they talked about their particular objectives, personal objectives of recovery, and having that emotional support as well. So some quotes. The support group explains why you feel these things, and then it gets to the root cause of why and how you should feel appropriately about stuff. It reinforces that you're not a bad person, you've just made bad decisions. And that was a man talking about the importance of support groups and people with lived experience leading them. This to one another, we bounce off each other. It's very, very, very positive. The feedback and the help you get, and if you don't understand something, the guy who runs it, he'll explain it in easier ways. Okay, so people talked about their context where they came to start using Buvidal, and also reasons for stopping it, if they'd moved on to something else. And sometimes a context where they needed to do something quite radical to get their kids back, or to get a placement in a particular supported housing. Some people heard about it from friends, and the need for information and awareness, I think, was highlighted in this area as well. And some people, who had sort of lapsed from taking Buvidal told me that they were not ready. They'd had too many restarts, and they were worried about the blocking effect, so that it takes away the choice of whether you can use or not. They didn't like the lumps in the skin. They found the clarity of mind and the emotions coming back just too much at that point in their lives, you see. So this idea that maybe we could use Buvidal as a sort of a stopgap thing sort of starts to come through in various people's experiences. And so context. I got out of prison. This is a woman. I got out of prison and I didn't just want to stay on methadone, because I knew that if I did, I'd go back to using. So I just sacked the methadone off and started on Buvidal. This is a man. Some people believe that something you have to have daily to feel well. There's no way you can have something once a month or even once a week for that matter, and it's going to keep you well. So this demonstrates, first of all, why people might decide not to start taking Buvidal, but also the need for information and awareness about, what to expect. This is a stakeholder. So if you're not addressing the other stuff and you might feel that it's not for you, you might not want the clarity that it gives you because you're not ready to deal with the trauma. So this is the idea that we need that wraparound help, just to get people over that, the emotions coming back and that clarity of mind. Everybody talked about futures. So people talked about, what they were thinking was going to happen when they came off Buvidal, when they were, planning to reduce down and come off. And they talked about needing to feel stable. So if there was a lot going on in their life, they were like, right, I don't want to think about reducing down. I just want to stay on this because it's keeping me on an even keel. People were worried about withdrawal, but the people that I spoke to that had finished taking Buvidal said that there wasn't significant withdrawal issues when they came off it, but that wasn't known, so people weren't sure what to expect. So this again shows the need for more information about, from the horse's mouth, about actual experiences. And people talked about futures in terms of what they wanted for their own future. So people were like, I want to go on holiday, I want to get a job, I want a normal life, but also priorities. So like the priorities for services, what people should carry on doing and what needs to be done. And a lot of that was about sort of wraparound support. So this is a woman, she says, at the minute, because I'm so stable, I don't want to take that away. The last thing I want to do is end up back where I was. And then this is another woman who's thinking the same kind of thing. My biggest fear at the minute is coming off everything because of how it makes me feel to withdraw. I've gone through it 3 times and I was really poor the last time, so it frightens me. So this man was talking about his plans for the future. I want to work in recovery myself. I hope to get to a point where I can help somebody before they get to how I was, even if I can only help one person. So just this idea of, having plans or ideas for your future coming through was really positive. So priorities in terms of, staff and stakeholders. This is a psychological practitioner at the beginning, addressing the adverse childhood experiences or the current experiences, developing that better sense of self in order to be able to cope. Developing supportive relationships is key, the framework around them in which people can feel they can cope and be supported in dealing with life's difficulties. So that kind of wraparound support is a priority for that person. And the stakeholder said, by engaging people, we can work on motivation. We can get people to reflect on their current situation without telling them that they should be considering recovery. The medication can be used to support treatment goals that people might have themselves. And by having them engaged, we can do more about considering what next. So this idea of priority for the stakeholder was bringing in people without this expectation, right? You're going to be on Buvidal and then you're going to do this, this and this, and just this idea of bringing people in and just giving them the choice, maybe in a sort of harm reduction kind of sense, and then they might consider what next, but there shouldn't be this pressure on people to fulfill a particular progression pathway. So there was a different opinion about who thrives on Buvidal. So the service users I spoke to said, people with a busy lifestyle, yes. People who want to engage with support and people who are ready to stop. So these people are the best people to give Buvidal to. If they're not ready to stop, then it's not worth it. It's not worth it. But the practitioners had a more sort of nuanced view. They talked about people who, without having the offer of something like this, they might be, lonely or lost to services, you know, people who are, well, classed as harder to reach, people in prison, people who've been on methadone a long time and they've just got in a kind of rut, and this is older people as well. And this idea that I've just mentioned, some public health practitioners were talking about the idea about giving people a break from taking drugs and seeing what happened. So this is a nurse. She's talking about who thrives on Buvidal. People that are street homeless who would find it difficult to go to the chemist every day. People who are at risk of being cuckooed or manipulated, at risk of financial abuse, so shouldn't be having drugs on their premises, in other words. And this is the idea, you know, which is different from the service users' idea about, you know, you've got to be ready to stop. You've got to want to do this, this, and this. This is the public health stakeholder who said, why don't you have a few weeks or a few months off, give yourself a bit of a break and see what that's like. I'm not sure that Buvidal's been sold that way. And I think we could refine the messaging far better to attract people in the short term and then be able to get them into better health interventions during that period, you know, that go forward into the longer term. So this is an interesting view that didn't come through in the literature at all, really, that we could be using this as a sort of way to draw people in, to give them extra support or offer them extra support. So one of the major findings was there's not enough information. So people were talking about the information that they were provided. It's quite formal. A lot of it was about speak to your GP. And people were saying their GPs weren't really aware about this medication anyway. So we found out that there was need for accessible information about the benefits, about the things that are offered, you know, that people can get involved with, this wraparound interventions, how it's administered, you know, the risks of lumps in the skin, how long you're going to be on it, you know, what to expect, interactions with different drugs and pain relief, and what to expect in terms of coming off and reducing down. And all of these things was kind of lacking. So that awareness and knowledge is really needed. And so this nurse was telling me about, you know, the lack of information. So she's spending the extra time going through the booklet with people and giving them the information that they need because it's not out there. So she says, I go through the booklet with them about it. I go through the things that don't work. I also tell them that it can be overridden if they're in a terrible accident, so they don't need to worry about that. So the lack of, you know, information even at that level, clinical level. And this is a man's service user. They've not mentioned about how long I can take it for safely. It was probably in the book and I've never read it. So they did give me the information. But yeah, maybe that could improve, you know, telling people what to expect, basically. So in terms of this lack of information, this is what we produced. So I recruited 2 people with lived experience and we looked at the sort of themes that were coming out and what they thought would be good bits of information to impart and the most important key sort of bits of information. And then Sue found a designer and we put together this leaflet and we sort of took it back to the service users and tweaked it lots and lots of times. And then we've sort of settled on this, and this is, you know, coming from the horse's mouth. So we're going to get that printed and sent round to services so they can distribute that. So it's accessible information that people think is important for others to know. So basically, what have we learned? That Buvidal works well for many people in Blackpool. And it's important for these kind of evaluations to get the perspectives of staff, service users, and sort of commissioners and stakeholders, because they can all provide this sort of holistic view, more knowledge and different perspectives. I think the key finding for me was there is a really big need for, rather than saying, oh, this is a wonder treatment, No, it's a wonder treatment if people are offered the right support that is right for them. So all this wraparound support coming from people who understand how they're feeling, you know, and there's not this sort of requirement for people to fit in this box. You do this and then you do this and then you do this. Just listening to people's priorities themselves for recovery and what they want to happen is really important. Also, yeah, we've talked about the lack of accessible information, so we're going to try and address that fully. And we need to do much more work looking at different settings, because there's different issues in prison with this treatment, you know, which will be like disengagement from practitioner staff. And the idea about outreach, you know, can we safely use injections in an outreach situation just to get people who wouldn't, you know, voluntarily engage with service, and things like residential services as well. So we would like to see future research in these different situations. Okay, so if you want any more information, please email me at Lancaster. It's r.fish1. I don't know who the original R-Fish is. I'd like to meet them. So please email me, and if you want the slides or anything, just let me know. Thank you.
Many thanks, both of you. That was fantastic. I don't know if you'd like to stop sharing, maybe.
I'll try and do that.
I think
maybe Sue has to do that.
So if anybody's got any questions, you could either, or comments, put them in the chat, or we've got a few minutes left of this session.
I don't have stop sharing.
Yeah.
Can you give me? Okay.
Perfect. So I know I was lucky enough to attend your dissemination event at Lancaster Castle, and it was, I would honestly say, one of the best events I've been to, because it brought it home like it was real life, because you had a service user there and it just brought it back, you know, to this is actually happening to people. So thank you for that.
Yeah, she was so brave. I was well impressed with her.
It was a fantastic event. And also, I've just got a couple of other points. I wondered, how long are people generally on Buvidal for? Do we have any idea of that?
So I think they're allowed to be on it for about a year. The people that I talked to had been on it for between 6 months and a year, but some of the people had stopped taking it and they'd come off and they were out the other end type thing, and those tended to have been on it for about 9 months. But you can get restarts, you see. So if you don't turn up for your appointment, they have to sort of reschedule the prescription and all that and start you on weekly again. So it's not as simple as just starting and then stopping.
Has there been any work done at all looking at people who've been taking Buvidal to see if they have remained, you know, off any type of drugs at all, or if they have maybe picked up again?
I don't know. What, like longer term after they've finished?
Yeah.
I don't remember any. Do you, Sue?
No. And I suppose just one other point I had. Absolutely loved the leaflet. That looks very impressive. What's the plan with the leaflet? Is it going to be circulated Blackpool wide, or
yes, our goal is to have it printed and share it with the services that receive participants that can be recommended to Buvidal, so people can get information from past service users and people that have gone through the same challenges.
Fantastic. I don't know if anybody else on this session has got any questions or comments at all. You can all, you're allowed to switch cameras and microphones on now if you would like. I think we've stunned people into silence, it appears. Oh, Michelle Collins has got a hand up.
Hi.
Michelle.
Hi. Can you hear me? Have I come off?
Yeah.
Great. Thank you. Thank you so much for that really interesting presentation. I just wondered about recruiting the service users. You had quite a large amount of service users there, which is really good to see. In terms of male and female recruitment, did you find any difficulties around that? In terms of gender difference?
The people who, it was mainly women who agreed. I don't know whether it's because I'm a woman and it was, they thought, oh yeah, I don't mind talking to her. But I don't know why, because I think it's 75% men at the service. But yeah, I think it's, well, I don't want to generalize, but the men seem to be a little bit more complex, so maybe more likely to be homeless and in sort of that kind of what's the word, where they're sort of they're in accommodation but it's not guaranteed, so not in a proper placement, sort of moving around. So maybe that's why, they were less confident, but yeah, it was mainly women that I spoke to. And so yeah, I probably should reflect on that in the publication, shouldn't I?
Just to say that we were also giving a voucher to participants. So people that had accepted to be interviewed, it was very challenging because Rebecca can talk much better about this than me, but people would say that they were willing to be interviewed and they would not turn up, okay, and mainly the interviews were conducted online or by phone. And I think that also has helped to get some of the interviews, okay. At the same time, for other people, for other participants, it might have prevented their participation. So but at the end, I think that it was quite a good sample of people that we got. But they were given a voucher every time that an interview was completed, just to help to recruit and retain.
Yeah, I sort of asked the question because I did some research on a trauma-informed service for people who use substances, and most of the people who responded to a request to take part in it were males. So I'm interested that you had, but I think there was a majority of males within the service. But yeah, it was difficult to get women sort of signing up for it.
It could be because sometimes I got the lived experience woman to help me. And I guess maybe the people who engage with the sort of activities and stuff are more likely to be women. I'm not sure.
That's interesting. Yeah, thank you.
Yeah, it is interesting. Thanks for the question.
Did you get feedback from people regarding receiving a voucher rather than cash?
Oh, the vouchers were hard work because, you get a code and they have to go to a website, and then if they mess it up, they don't end up with the voucher, and it was just really hard work. So I would rather have given them more money and just given them cash, but that's always going to be an issue with people who are at risk of using drugs, and also getting it to them. So I don't know the right answer.
Yeah, it's not only with people using drugs, it's also for ethical issues. We cannot give people money, okay? So the voucher is the token of appreciation, to recognize the time. It's not to pay for people's time, so it's not a lot of money. I can't remember from the top of my head how much it was. It was something between 10 or 15 pounds, I don't know, but it's more a token of appreciation than to pay for people's time. And because we don't want to get people into answering just for the money, okay? We want people to be committed with the research as much as possible. And and also ethical. Well, we would never get approval from the ethics committee to give people money for any kind of situation. Okay, it's not only people with the drug abuse problem, so it would be for any disease, anything. So it's because there is also a very clear guidance about what can be given and what cannot be given to participants. Okay, and so we have to abide by all that guidance, and I think it's fair. Okay, so I'm not complaining. I think it's fair. So it's just not possible to give money, in spite of the fact that, of course, people would prefer, especially people in this situation, not because of the situation itself, but because they struggle sometimes to navigate stuff online, okay? And as Rebecca was saying, then they need to get the code and then use the code and so on, and it wasn't really straightforward for some of them, okay? So that was a challenge, but well, we did quite well at the end anyway.
Yeah, in the end.
I don't know if anybody else has got any final comments or thoughts? No? That's it. Oh, Tim, maybe, did you want to say something?
Yes, please. A sort of quick question as well. And to fully declare my position here, I'm involved in an evaluation of Buvidal within Midlands Partnership Foundation Trust at the moment, smaller scale than the one you've done. And I was also in a session with you, Rebecca, at the Drug Deaths Conference earlier in the year. And my question to you specifically is, were there clinical inclusion and exclusion criteria for people receiving Buvidal in Blackpool? I'm not talking about sort of research inclusion criteria, but were there clinical criteria for who got Buvidal?
Hang on a minute.
I can answer. Initially,
okay.
there were some clinical criteria, so we slightly changed the goal of the evaluation. Okay, so because at the beginning we intended to evaluate a specific program where patients had very clear inclusion and exclusion criteria to receive Buvidal, but then the program wasn't recruiting very well. Okay, so we just open up the evaluation to any participants receiving Buvidal, and not only those that were meeting the inclusion criteria for the first project that was ongoing. I don't know if this, I think this more or less answers your question. So we didn't make, so what can be said, okay, is that the first program, that the first intervention that was developed in Blackpool, they had quite strict criteria in terms of the characteristics of the patients that they were looking for inclusion in that intervention.
Mm-hmm.
It was difficult to recruit those participants, so at the end they also had to, well, the recruitment was very low, so if we wanted to do something, we just have to not only to look at those patients but also to other participants that were receiving Buvidal that had been given or decided to be given based on different circumstances.
Mm-hmm.
I was going to say they started off with a very narrow, because of the cost, who they were going to allow to take Buvidal, and then the drugs company that provide Buvidal said we can give you money saving if you have more people on it. So they opened it out and offered it to more people. So at first it was given to people who had been on methadone for a long time, and then they opened it out to more people who were in residential recovery services as well. But I can't give you the details of that. I did speak to Abida Mohammed about that, but I don't know how that's evolved over the time, to be honest.
Okay, I've got the same issue, you see, with it, because looking at it across 6 counties, the commissioners have only commissioned 100 courses of Buvidal, 20 per county, effectively. So it's an issue of how those get allocated. Anyway, I'll send you an email about it later.
Yeah, okay.
Thank you.
Brilliant. I don't know if anybody's got anything else, or if we'll wrap it up to a date for today.
Just let me say, we will be publishing a paper based on these qualitative findings, and we are also aiming then to have another paper later on based on the quantitative analysis that we are still doing.
Excellent. And we could also maybe have another seminar in the future looking at the quantitative
sure.
data. Yeah, perfect. That's brilliant. Thank you ever so much, both of you, for leading today.
Thanks everyone for coming.
Lots of food.
And thank you again for the funding. Without the funding from NIHR, there would be no presentation of the project.
You're very welcome.
Thank you.
Thank you.
Thanks.
Bye.
Nice to see you all.
Bye-bye.
Bye.